patient in the OPD, you should dilate and do a 90-day evaluation and see critical elements in the optic disc. The first part is that you see the outer part of the optic disc. So basically you have to determine what is the size of the disc, it is a large disc or a small disc. You see what is the shape of the disc, whether it is circular or vertically oval. A very important thing is to see the tilt. You see whether the vascular root facing you is head on or whether it is tilted. Then you see around the disc for any peri-papillary atrophy, any retinal nerve fiber layer defects, and finally if there are any disc hemorrhages which are traversing the margin of the disc. So this is very important. The first part of the evaluation of the optic disc is the outer part of the optic disc. I will repeat again: the size, the shape, the tilt, peri-papillary atrophy, retinal nerve fiber layer defects, and the disc hemorrhage. After that, you go to the inner part of the disc, that is basically the cupping and any vascular changes. So you delineate the cup disc ratio. There is a lot of confusion in this. What is CD ratio? CD ratio is basically the vertical cup disc diameter ratio. This is what you mean by CD ratio. Then you look at the neuroretinal rim, and for that you have to remember the ISNT rule that states that the healthy neuroretinal rim is thickest inferiorly, followed by superior, nasal and temporal. So anytime when this ISNT rule is flouted, you think that patient may be having neuroretinal damage due to glaucoma. Very important thing is to see for the pallor of the optic nerve head, whether the pallor is more than the cupping or the cupping is more than the pallor. Then you look for notching of the superior or inferior neuroretinal rim. And finally, the depth of the cup. And most important thing, if you don't have any of these investigations available, you can just take a disc photograph or make a drawing of the disc. And when you follow up the patient over 6 months or 1 year, you see whether these changes are progressive or no. Because glaucoma is diagnosed by progressive optic nerve damage over the time. The first test, how to evaluate the size of the optic nerve head, you can use the smallest aperture of your thermoscope, put it on the optic disc. If the size of the optic disc is larger than this spot of light, it is a large disc. If it is smaller than this, it is a small disc. This is a very simple test which you can do with a direct ophthalmoscope to give you an idea of the size of the optic disc. It is very important to remember why we are interested in the size. Because as the size of the disc increases, the size of the cup will increase. So you may have a patient with -10 myopia who has a large disc with a 0.7 cupping, which is not glaucomatous because he has a large disc. The second thing I already explained to you, it is very important to focus on the neuroretinal rim and see the width of the rim. Normally the inferior is maximum followed by superior. The third thing which is a bit confusing is the peri-papillary atrophy. Now this is the area of the disc. You can see at the margin of the disc you have two zones, the beta zone and the alpha zone. So the beta zone is the one which is very important for glaucoma. It denotes basically area of atrophy of the retinal pigment epithelium and choriocapillaris. And this may tell you where is the area of damage occurring in glaucoma. And if this peri-papillary atrophy progresses, that may be a sign of progression glaucoma. Adjacent to this is the alpha zone, which is not so important, that is basically area of hypo and hyperpigmentation. This beta zone is very important. It helps you to determine where is the margins of the neuroretinal rim. And also, if it is present in one particular area, you focus on that, may be the area where there may be neuroretinal rim changes. Just to give you one example, you can see two discs. This is the area of peri-papillary atrophy. This should not be confused with the disc margin. So this is the disc margin and this is the adjacent area of peri-papillary atrophy. This is very important to distinguish, otherwise you can erroneously make it a large disc. Another important thing is to see for two very important findings. One is asymmetry. If the asymmetry of cupping between the two eyes is more than 0.2, that is suspicion of glaucoma. And what is the color of the rim? You can see the pallor here is much more as compared to the other eyes. So whenever there is pallor with cupping, you must think of diseases other than glaucoma and order neuroimaging in the form of CT scan and MRI to rule out any space occupied regions. The other important sign in glaucoma is to follow these blood vessels and see where the blood vessel is bending. So wherever the blood vessel is bending, that denotes that is the site of the neuroretinal rim. This is a very classic sign. You can see the blood vessel emerging from the center of the optic nerve head, disappearing here and suddenly appearing. This is the classical bayoneting sign. It is a vascular sign of glaucoma, and you can see it is occurring in the region of the Peri-Papillary Atrophy. So wherever the vessel is bending, that denotes the edge of the rim. Sometimes it is difficult to delineate what is the cup margin. So with a thermoscope or slit lamp, with a red-free light, you will notice the vascular markings become more accentuated. So with the red-free light, this will appear black, and there you see where the vessel is bending. So that bend in the vessel denotes that this is the area of the neuroretinal rim where there is an atrophy occurring. The other important thing which you often miss on clinical evaluation is the retinal nerve fibrillary defects. These are the earliest signs of structural damage in glaucoma. You can see on the disc photograph, you have this wedge-shaped defect which is not present superiorly. You have these fine streaks. This is the normal retinal nerve fiber layer, and you can see in the inferior part these streaks are absent. The vascular markings become more prominent. So this is a classical wedge-shaped retinal nerve fiber layer defect that is visible. That is an early sign of glaucoma. You can see here this broad wedge-shaped defect emerging from the edge of the disc. So these are classical retinal nerve fiber layer defects that point to that patient is getting an early damage due to glaucoma, and these will correspond to a superior visual field defect. Now compare these two photographs. You can see these white streaks emerging from the disc. This is the classical normal retinal nerve fiber layer which is visible. So normally you are always looking at the disc, but start looking around the disc into this retinal nerve fiber layer. And if you contrast it with this picture, you can see there is an absence of these white striations that denotes a diffuse atrophy of the retinal nerve fiber layer as compared to this eye, which is a normal retinal nerve fiber layer. So I am going to take you to an interactive session. So all of you can volunteer. Okay? Maybe in 15 seconds, whatever you want to answer, there is nothing, you don't feel shy, because that is how you will learn. Is this disc normal or abnormal? Normal. Very good. So never look at the cup. Always look at the neuroretinal rim. So patient has got a very healthy neuroretinal rim. There is no notching, and you can see these white streaks available. This is a healthy retinal nerve fiber layer. Many times, because of the large disc size, this is a myopic patient, this is confused with glaucoma. This is physiological cupping in a patient with a myopic large disc. What about this? So two important signs. One is Peri-Papillary atrophy. Whenever you get this large Peri-Papillary atrophy, it is usually associated with a tilted disc. Now if you compare these two, you can see here, you can see the vascular trunk directly head on, and here you can see the vascular trunk is hidden. So always see a perpendicular coming towards you from the center of the disc. So here it is coming directly on you. Here the disc is tilted temporally. So this is very important sign. This is a tilted disc. Whenever you have a tilted disc, you cannot comment on the ISNT rule. So this is a tilted disc associated with Peri-Papillary atrophy. Again, vascular trunk is in the center facing you. Here the vascular trunk is hidden behind the rim. That means the disc has been tilted. What about this? Very good. So this is a disc hemorrhage. The importance of disc hemorrhage is it's an alarm bell. So if you see a patient, suspected glaucoma patient who has developed disc hemorrhage, you have to follow the patient at 4 to 6 months interval and watch this area. The patient may develop a progressive thinning of the neuroretinal rim in this area, and this may lead to a retinal nerve fibrillary defect. So this is an alarm bell. If disc hemorrhage crosses the disc margin, this is a subtle sign that the glaucoma may be progressing. What is the finding here? So always see, I told you ISNT rule. the inferior ring has to be thickest. So if you are seeing the ring here, normal, and here you see there is a notching occurring. So this is the early sign of glaucoma, notching of the inferior neuroretinal ring, which you can pick up easily if you follow the ring. So normally residents say just look at the cup. So stop looking at the cup. Always look at the contour of the neuroretinal ring and where it is getting damaged. So here you can see it is confirmed that there is an inferior retinal nerve fiber layer defect corresponding to the area of the notching. That confirms that it is a glaucomatous thinning of the neuroretinal ring. What about this? Anybody from the back benches? So there are only two answers, normal or abnormal. You can see this is white on both sides. So this patient is a glaucoma suspect. This area is looking slightly that there may be a thinning starting. What about the other eye? So I told you two important things. Whenever there is a peri-papillary atrophy, look at that area first. There will be something wrong happening there. So can you see what is going wrong? Compare the superior neuroretinal ring with the inferior neuroretinal ring. Which one appears damaged? Very good. So now you can see this is the peri-papillary atrophy. Superior ring is okay. There is an inferior neuroretinal ring damage which is starting to occur. So this is a subtle sign, inferior notching, which is occurring. And there is a lot of debate. Sometimes you are not able to confirm. Somebody may say this is glaucoma, somebody may say this is normal. So you can see this is a HRT that has been done. The left eye is normal, right eye, that suspicious area is crossed. So definitely there is an inferior thinning. You can see here, there is an inferior retinal nerve fiber there loss. So you don't require this investigation, just need to confirm. If you are very careful, you can easily pick up that there is a thinning of the neuroretinal ring occurring. Normal, abnormal. So don't look at the cup. Okay, so you can understand how important it is. You are getting all three answers. Somebody is saying glaucoma, somebody is saying suspect, to be safe, and somebody is saying normal. But you see, there is a very healthy neuroretinal rim. So this is the normal disc. Very healthy, symmetrical neuroretinal rim, and the vascular trunk is facing you, it is not tilted. Healthy neuroretinal rim. Yes? So the two findings, you have to be very careful. So all of you are again concentrating on the disc. If you see here, this is a very subtle sign. You can see difference in the color between this part of the retina and here. This is an RNFL defect. So patient has an inferior neuroretinal rim damage. This is glaucomatous. Can you appreciate the difference between the color of the retina here and here? So where there is an RNFL defect, you will have increased visibility of the blood vessels. So this is again a myopic patient, slight tilted disc with a peri-papillary atrophy which is visible. Anybody? So what is the difference between this picture and the previous one I showed you? The pallor is more than the cupping. Okay? So this is very, very important sign. Never label such patients having glaucoma. We get young patients, 35-year-old with pallor more than cupping. And sometimes you can just diagnose that patient has got an intracranial lesion. Refer for MRI, you can see there is a tumor in the brain. So always pallor more than cupping is something other than glaucoma. Normal, abnormal? Absolutely healthy disc, the white striations of healthy retinal nerve fiber layer with a healthy neuroretinal rim. Normal, abnormal? So always compare superior superior RNFL, white striation with the inferior RNFL. You can see this wedge-shaped defect. So that is going to tell you, even though the changes in the discs are not very apparent, but there is an inferior retinal nerve fiber layer damage. That is why for glaucoma patient it is best to do a dilated 90 evaluation and see your retinal nerve fiber layer. And if you are not sure, take a fundus photograph. On the fundus photograph, always look at the retinal nerve fiber layer. This will become very clear for early glaucoma. This one? Very good. See superior white striations and inferior this wedge-shaped defect from the disc margins. So this is an inferior RNFL defect in a patient with early glaucoma. Here the two residents sitting on the last bench. Your visual acuity is 6/6, no? You please comment on this. Yeah, please stand up, It will wake you up. Very good. And the left resident? Yes, you agree, disagree? देखो बहुत सारी चीजें देखनी है ना, साइज, शेप, कलर, रेंज, इतना चीजें बताया आपको. ये white दिख रहा है ना? So I tell you, this patient is the doctor on glaucoma therapy for last 10 years. Referred for second opinion. He is taking 2 drugs. Patient is a bio, -8. Okay, this is a large disc with a large cup, but you see the ring screen here and the RNFL looks healthy. And this is the OCD. Okay, so I stopped this treatment. Absolutely with normal retinal nerve fiber layer. No glaucomatous damage, just a large disc with a large cup. Healthy new retinal layer. This is glaucoma patient. The hint I give you post trabeculectomy. You can ask Gunjan only. So there is some blurring in the disc margin. I don't know how clear it is coming. Some folds in the macula. So folds in the macula with blurring of disc margin post trabeculectomy. Very good. So this is hypotony maculopathy. So I'm just going to show you when you put in a gonioscope. ये लाइट्स बंद और डिम कर सकते हो?
थोड़ा सा आगे वाला खाली करो.
So whenever you put in a gonioscope, answer these 8 questions. So first one is, what are the angle structure visible? If the scleral spur is visible, denotes an open angle. Second question, does the iris touch the trabecular meshwork? If yes, what is the extent of touch? If it does not touch, is there any evidence that previously it was in contact in the form of pigment? Fourth question, if there is a contact between the iris and the trabecular meshwork, is it reversible or no? Next question, what is the degree of angle pigmentation and what is the convexity of the iris? It is concave, flat or convex? Are there any new vessels in the angle crossing the scleral spur, that is NVI or NVA? Is there any evidence that is a developmental anomaly in the form of prominent iris processes or an anterior displaced Schwartz's line? And finally, for glaucoma patient, whether the trabeculectomy ostium is patent or no, all this information you can get on gonioscopy. So the first question is, are the angle structure visible? So this is the video to show you the normal angle. Iris, this white area is the scleral spur, followed by the pigmented part of the trabecular meshwork, non-pigmented and the Schwartz's line. So concentrate, go up the iris, scleral spur is visible and the trabecular meshwork. So this is a normal open angle. You put in a gonioscope, you see this white zone and this dark zone. So you know angle is open. Angles are visible. and very narrow silky body band is visible, though it is not so clear in the video, but scleral spur and trabecular meshwork is clearly visible. Which angle is this? Superior angle. Okay, open or closed? Scleral spur visible, trabecular meshwork visible. Okay, so understand first, this is the trabecular meshwork and this is the scleral spur. So this is how actually you will see when you put in a gonioscope. So easily you can say the angle is open because scleral spur is visible. Superior open angle, scleral spur and trabecular meshwork visible. The other important thing you have to see is whether there is any pigmentation in the angle. What is the level of pigmentation? So here you can see this part is the silky body band visible and there is an increased pigmentation of the trabecular meshwork with scleral spur visible. So this is an open angle with an increased pigmentation. Now I am showing you a patient who has had pseudophakic patient. Post cataract surgery, you can see open angle with dense pigmentation. So whenever you do gonioscopy, comment on the degree of angle pigmentation and whether the angle is open or closed. Make a slit. In open angle, you will see a continuity of the slit. So it goes up the iris into the angle. You can see a fine linear slit. The entire length is visible, there is no parallax. So that is the important sign of an open angle. That a continuous beam of light is visible. What is this? Modern art. So whenever you put in a gonioscope and you see this dense pigmentation, uniform, both in the superior as well as inferior angle. Inferior angle you might get due to the gravity. Superior angle, if you see this sort of pigmentation, uniform, there is only one diagnosis, pigment dispersion syndrome. Okay? This is a gonio video, you can see this dense uniform pigment. The pigment completely occluding the trabecular meshwork. So whenever you see this uniform band of pigment, especially superior angle, pigment dispersion syndrome. This is very classical sign, you have not seen any other condition. The second question, is there any iridotrabecular contact? Basically, is the iris touching the trabecular meshwork? So this is the most important sign on gonioscopy. You can see open angle and here the iris is in contact with the trabecular meshwork. This is very important sign. You please look carefully. Angle open. Here iris is touching the trabecular meshwork. So this is what is known as peripheral anterior synechia. Half of the angle is open, the other half is closed by peripheral anterior synechia. So whenever you see that the iris, here you can see in the center trabecular meshwork is visible and scleral spur is visible. On either sides, the iris is touching the trabecular meshwork. This is the peripheral anterior synechia formation. On adjacent side is the central open angle. That denotes patient has got an angle closure disease. Sometimes you may not find synechia, but there may be evidence of previous iridotrabecular contact in the form of pigment clumps in the angle. The other important sign is if you put in a gonioscope, you saw the open angle. So whenever the pigmented part of the trabecular meshwork is not visible, that denotes that patient has got an angle closure disease. You have put in a gonioscope, only the iris is visible and the cornea. There is no structure visible. So in one go you can say patient has got an angle closure glaucoma. Immediately he can be referred for a laser iridotomy phakic patient. The angle structures are not visible. Okay, you saw in the previous open angle, you saw scleral spur, trabecular meshwork. Here only iris and cornea is visible. Again, only iris and cornea visible. Completely closed angles on gonioscopy. The other important sign in gonioscopy is the apex of the corneal wedge. So what will happen many times, you will see this pigment Is this tubercular network or no? That is the question. So for that you need to angulate the slit lamp 15 degrees, make a narrow slit and do the wedge test. So this is the band of pigment. Is it tubercular network or no? So you have to make a 15 degree angulation slit lamp, make a narrow slit, you will see two beams of light. The posterior beam is from the corneal endothelium, the anterior beam is from the corneal epithelium. Where the two meet, that point is the starting point of the angle or the Schwab-Base line or the termination of Descemet's membrane. So you can see this segmentation is anterior to the apex of the corneal wedge. That means it is anterior to Schwab-Base line. That means it cannot be tubercular network. Patient has got a completely closed angle. This is pseudo-pigmentation present anterior to the tubercular network. This is the corneal wedge. You can see on the slit lamp two beams of light, corneal endothelium, corneal epithelium, it is meeting here. So this is the Schwab-Base line, the starting point of the angle. So whenever you do gonioscopy, you have to do this wedge test. 15 degree angulation on the slit lamp, narrow the beam, you will see these two beams of light. Where they are meeting, that point is the apex of the corneal wedge or the Schwab-Base line. That is very important sign on gonioscopy. You can follow the contour of the iris, see the two beams, and here they are meeting. The other important thing of the angle closure is the parallax of the beam. So you are doing gonioscopy. Is it open or closed? Definitely you cannot see the tubercular network or the scleral spurt. It's a closed angle with a convex iris configuration. And now make a narrow slit beam. You can see these two beams are not meeting. You saw an open angle with a continuity. So this is what is known as parallax of the beam. These two beams are separated from each other by a distance. That is the sign of angle closure disease, parallax on the slit beam. And the apex is going behind the iris. That means Schwab-Base line is not visible. What is this? This is sine wave configuration. So the first hump is due to the equator of the lens. The second hump is due to a prominently anteriorly displaced ciliary body. This is a patient angle closure post iridotomy. Angle is not opening. So gonioscopy you see peripheral hump. So there is a plateau iris. This is known as plateau iris configuration, sine wave configuration. That is a very critical sign in gonioscopy to identify plateau iris. So after you have seen the angle and your diagnosed closure, you have to ask the next question whether this closure is reversible or no. That you can answer by two techniques, manipulative gonioscopy or indentation gonioscopy. Manipulation is done with the Goldman type lenses. Primary position, the angle structure are not visible. So you ask the patient to look up towards the mirror. Now you can see this white area becoming visible. So the scleral spur has become visible. So primary position angle was not visible, but when you ask the patient to look up, the scleral spur has become visible. This is manipulation gonioscopy to identify whether closure is reversible or no. This is indentation gonioscopy. Primary position only iris cornea visible. Now you press and you see the angle opens up. So this is indentation gonioscopy of pushing aqueous into the angle, opening up the angle. Now see this other video. Primary position, iris cornea visible. Now watch carefully. When you press the gonioscope, push aqueous into the angle, you can see this fine synechia becoming visible. So on pushing aqueous into the angle is opening up, but synechia has become visible. So that denotes patient has got a synechial angle closure that is visible on indentation gonioscopy. It is not clear, it requires a lot of practice to pick up this technique. Basically, you are pushing aqueous, pressing the cornea and telling whether iris opens up, the angle opens up or no to distinguish appositional closure from synechial closure. Now till now you have seen the synechial closure of angle closure glaucoma. There may be other type of synechia present. This is broad-based synechia in a patient of uveitis. You can see very different from the angle closure synechia. Very broad iris strands going, attaching to the cornea. So in a patient with granulomatous uveitis with secondary glaucoma. So whenever you see these thick bands of iris going up according the angle, that is sign of a broad-based peripheral synechia, hallmark of uveitis. This is again secondary angle closure uveitic patient, completely closed angle with pigmentation anterior to short-base line, which you can pick up on the wedge test. Anybody, what is this? Yes, back benches. Anybody from the last two rows? Yes, front row. Very good. Very, very important sign. It took me 10 years of training to learn this. This is a blood vessel coming here from the silvery body going onto the tabecular meshwork. So this is a patient now diabetic retinopathy. You can see angle is open. Some areas it is getting closed. High pressure. This is new vascularization of the angle. Very critical sign picked up on gonioscopy. Immediately patient is referred for pancreatic photocoagulation and you can reverse the disease process. If you wait 2 weeks, it will become closed. Like this patient. You can see the blood vessel here. Complete cycle closure of the angle has occurred. New vessel glaucoma, very difficult to treat. Very critical to see new vessels. If they cross the scleral spur, that is pathological. Ectopia media, you can see the new vessel of the iris completely closed angle. That is why it is very critical to pick up this at early stage. Now contrast the previous synechia with this. You put in a gonioscope, whenever you will see this anteriorly displaced iris attached to a band-like structure, this is hallmark of anterior segment dysgenesis. Juvenile glaucoma, Axenfeld Rieger syndrome or the ICE syndrome. So here there is a prominent anterior displaced short-base line and the iris is going and attaching to this line. This is the hallmark of a developmental anomaly in the angle. Again you can see anterior displaced short-base line, the iris strand going and attaching to this line, they contract and then lead to polyporia and correctopia. So this is a patient of Axenfeld Rieger syndrome. This sort of anomaly is diagnostic for a developmental anomaly of the angle. ICEC syndrome, you can see very anteriorly displaced iris. So the iris goes and attaches to an abnormal corneal endothelium, causing a secondary rise in intraocular pressure. You will be asked this question, how to distinguish prominent iris processes from peripheral anterior synechia. Peripheral anterior you have seen in the previous slides. They are very different from this. This is prominent iris processes, fine filiform strands of the iris that go into the angle structure. They will not be convex, they will not be tented up, they will constrict to light stimulus. So this is the anterior insertion of the iris in the form of prominent iris processes, hallmark of again juvenile glaucoma or a primary congenital glaucoma. Sometimes this is a very subtle finding. You can see this iris strands going and attaching to the tabecular meshwork. So this is what is known as the anterior insertion of the iris that you can pick up in patients of juvenile glaucoma. The iris is going and attaching to the tabecular meshwork in a patient with a very deep anterior chamber. This is not angle closure. It is following a concave iris configuration. The iris is going up and attaching to the angle. Prominent iris processes, fine filiform strands of iris going and attaching to the tabecular meshwork or beyond. These are prominent iris processes. You see these strands of iris, fine filiform strands going up the angle. So this is prominent iris process, very different from peripheral anterior synechia, and they will constrict to the light stimulus. Contrast with peripheral anterior synechia. You can see iris is tented up, including the angle structure, so there is no filiform process visible. This is peripheral anterior synechia. So this is how to distinguish these from the iris processes. This is a widening of the ciliary body band, hallmark of angle recession. Post patient had a cricket ball injury, he has come after 8 years with glaucoma. That is why it is very critical to pick up this widening of the ciliary body band, always compare with the fellow eye. So if one eye has an irregular widening of the ciliary body band, that is what is known as angle recession. These patients require lifelong follow-up because glaucoma can occur 10 to 15, 20 years after the injury. This is iridodialysis, disinsertion of the iris from the root of the ciliary body.
Tanuj, you have 8 minutes.
Okay. This is intraoperative gonioscopy, coipice lens, disinsertion of the ciliary body from the sclera. This is a cyclodialysis cleft. So on gonioscope, on the table you put in these lenses, coipice lenses, inject viscoelastic, and here you can see there is a cyclodialysis cleft visible. This is just before repair. Then this is post-vitrectomy. These pearls in the superior angle, no other condition, post-vitrectomy glaucoma due to emulsified silicone oil. Very characteristic picture, you cannot miss the hyperolia. And finally, this scar on the sclera, this is a patent trabeculectomy ostium. Patient post-glaucoma filtering surgery, you will see this cleft in the sclera. So this is a patent trabeculectomy ostium visible through the gonioscope. This is a superior angle. This is very important to diagnose what is the failure of trabeculectomy. Put it on the gonioscope and you will see this cleft in the sclera. Another video, you can see this cleft in the sclera visible. Some pigment is coming here, but this is an open cleft in a patient with normal intraocular pressure post-trabeculectomy. So this is how the trabeculectomy ostium is visible on gonioscopy. Another important thing is to recognize how you recognize that the drainage is blocked. Here you can see the iris is plugging the ostium. This is the ostium. The right half is closed by the iris. So this is very important sign to pick up on gonioscopy whether the iris is blocking the trabeculectomy ostium. This patient who had a shallow AC post-surgery and then developed a late increase in intraocular pressure. Finally, you might have experienced seen the animal glaucoma valve. This is a gonioscopy picture video. Patent tube of the animal glaucoma valve visible. Sometimes this can be blocked by debris or a blood clot. So on gonioscopy you can see the patency of the trabeculectomy ostium. Nowadays, we also use gonioscopy for therapeutic purposes, and this is a surgery known as gonioscopy in chronic angle closure. This is a Susan-Jacob lens. So after cataract surgery, through the gonioscope, we are doing this surgery. It's called gonioscopy. You are teasing off the iris of the trabecular mesh. You can see the scleral spire getting exposed. So you are breaking the peripheral synechia from the trabecular meshwork. So this requires very good knowledge of the anatomy of the lens. Now, a number of new surgeries are coming in the field of glaucoma surgery, where you are doing a gonioscopic guided surgery. This is a hydrous implant. So this implant is inserted into the Schlemm's canal. So unless you learn gonioscopy, there is no way you can do these procedures. This is intraoperative gonioscopy. I have covered the diagnostic uses. These are the therapeutic uses. In addition to the laser trabeculoplasty. This is an intracranicular implant. So finally, at RP Center, we have prepared from the last 10 years our collection of gonioscopy with these videos. So this is a gonioscopy atlas. If you want to learn more or refer the reference material, we have prepared this atlas from RP Center. This has got an atlas with a text plus gonio videos to show you how an open and closed angle is visible. And finally, you have seen the amount of photography and videos in this is possible with three of my very nice residents from RP Center, Dr. Rohit Agarwal, Manish Mahavir, and my senior resident Amit Sopti, without whom this presentation would not have been possible. And thank you very much for your kind attention.